Hi, I'm Amit Khera, Director of Preventive Cardiology and Professor of Medicine at UT Southwestern Medical Center. Great to be with you from the ACC Scientific Sessions. I'm joined by three fantastic colleagues to go over some of the late-breaking clinical trials, some of the really exciting science. And I'm going to start first with Dr. Alanna Morris. She's an Associate Professor and Director of Heart Failure Research at Emory. Welcome, Dr. Morris.
Thank you. Glad to be here.
Well, we're going to talk about the sodium AHF trial. I mean, hard to believe that we've been telling people not to consume sodium with heart failure for so long, and it actually really has not been studied well. What are your thoughts on this study?
So I think this is great. I think it's wonderful that we do have sort of well done randomized data, because you're absolutely right, Amit. We tell patients to limit their sodium intake all the time without data to really guide that. I think now we have that. Of course, this intervention actually randomized patients to a low sodium diet, less than 1,500 milligrams. And the investigators found that the intervention didn't actually reduce clinical events, but it did improve quality of life in New York Heart Association class. So I think it's important for us to sort of put this in the context of other studies that have shown similar findings. And I think for us as clinicians, we have to remember that, of course, we want patients to engage in good self-care. Excessive sodium intake is bad, but I don't think that we necessarily have the data to beat patients over the head with very, very restrictive sodium guidelines. I think that's very important. In fact, we've seen other data that have shown that very rigorous sodium restriction may actually be harmful for patients with heart failure.
Okay, not our super consumers.
Yeah.
What are your thoughts for those who consume more sodium?
Well, I noticed that because the U.S. wasn't included in this study, and I was impressed by the fact that the average intake was 2,200 milligrams. It would be interesting if this study had been done in other countries where the average sodium intake was higher, which we have seen in some of the studies in the U.S., that perhaps there might have been a benefit in terms of clinical events. So I think that's a really great point on it.
Okay, well, thank you for that. I think we're going to move on to our next study. We're going to hear from Dr. Kathryn Lindley, who's an Associate Professor of Medicine and OB-GYN at the Washington University School of Medicine. She's also Director of the Center for Women's Health. The CHAP study, I have to say, this is one that probably will be one of the most memorable of these sessions, an area where we're not seeing a lot of research, but there's a critical need. So tell us about your observations and thoughts on that study.
Yeah, well, I think, in the OBGYN and cardio-obstetrics world, this was a much anticipated study and one that really needed to be done. There have been some discrepancies in the guidelines between ACOG guidelines and ACC AHA guidelines in terms of management of hypertension goals for some time now. And so this study really looked at treating mild chronic hypertension in pregnancy, which has classically been treated just to a goal of less than 160/110 during pregnancy, primarily out of concern of causing fetal harm due to reduced placental flow and potentially leading to fetal growth restriction. And so in this study of about 2,400 patients, they actually treated to a goal of less than 140/90. And what was found was that they met their primary endpoint, which was a composite of preeclampsia with severe features, preterm birth of less than 35 weeks, abruption, and neonatal or fetal death. And that was really primarily driven by a reduction in preeclampsia with severe features and a reduction in preterm birth at less than 35 weeks. And importantly, there was actually, no evidence of harm for their safety endpoint of fetal growth restriction or abruption or other negative fetal outcomes. And so I think that this tells us that there's benefit to mom to treat to a lower blood pressure goal, and we're not causing harm to baby.
Well, listen, incredibly important study, and there's so many take homes, but one of the biggest ones is the necessity for high quality research during pregnancy. I mean, there's a dearth of this. The fact that this has not been studied before is impressive in of itself. Tell me about your thoughts on the necessity and how this hopefully moves the field forward.
I think this is really critical. And, not only that the study was done, but also that it was presented as a late-breaking clinical trial at the ACC. I think it's really a signal to the cardiovascular research community that, it's the right thing to do for pregnant women and lactating women and women as a whole to include pregnant women in our clinical studies. These patients have sort of traditionally been excluded from clinical studies as they've been seen as sort of a vulnerable research population. But The reality is these are patients who still have full capacity to make informed decisions about whether or not they want to participate in studies. And I think as long as there's good safety data from early animal-based studies, we should be offering these patients the opportunity for both them and their fetus and infant to participate in studies, which will really better inform the ability for us to care for these patients on a broader population level over the long term, as well as then provide better care to women throughout the lifespan. So I think we really need to have a shift in the way we think about taking care of women, and particularly women of reproductive age, to consider them really essential to be included in clinical studies.
Well, for our last study, we're going to hear from Dr. Chiadi Ndumele. He's director of the Heart Failure Prevention Program at Johns Hopkins. Dr. Ndumele, we're in the middle of a pandemic here, and so vaccines are top of mind. Tell us about this international vaccine study presented.
Definitely a very timely study, Amit. It's the IVVE study that examined the impact of influenza vaccination versus placebo in patients with heart failure. It was actually done in low and middle income countries where flu vaccination rates are currently low, and people in the placebo group were actually allowed to get flu vaccines regardless, but very few of those actually did. And it basically examined the impact on various outcomes. The primary composite cardiovascular outcome was not actually different over 3 years. Between the groups that were getting consistent flu vaccination versus the group that did not. However, there were some very important secondary outcomes that were different. Hospitalizations of all cause were lower in the flu vaccination group, as was the rates of pneumonia as well. Interestingly, when they actually broke the data down by looking at whether it was during flu season or not flu season, they found that the primary outcome, composite cardiovascular outcome, was actually significant during the flu season, indicating that when flu transmission is high, we did see some impact on cardiovascular outcomes. So a very important study. It does have some contrast with some of the prior studies that were occurred, most notably the IAMI study of vaccination in post-MI patients, but has some really important take-homes in terms of the importance of vaccination regardless.
You bring up a great point in contrasting to prior studies. I guess the question is it that they did choose a little bit of a funny heart failure, an atherosclerotic endpoint for a heart failure study? At the same token, we have other data in prior trials, as you talked about the IAMI study. So what are your thoughts? Is this because it's a heart failure population, the wrong endpoint, or something else?
Yeah, I think it's actually going to be complicated to tease out, but I do think that there are a couple of things at play. So it's very possible that there's some differences in terms of the pathophysiology and with between AMI patients, recent AMI patients versus patients with chronic heart failure, and that's a real possibility. It's also possible that the outcome, which is more, as you said, an atherosclerotic vascular outcome, may not have been quite as appropriate for this population, even though a good percentage of them, about 20% of them, had prior MI. But I actually think maybe the primary issue is one of competing risk. So if you look at this study, about 15% of individuals in this study had the primary outcome compared to about 6% of individuals in IAMI, which I think really indicates how much pathobiology and adverse outcomes are related to the clinical circumstance. In this case, we had 30% of patients who were New York Heart Association class 3 or 4, 30% of patients who had low ejection fractions, less than 30%. So I suspect that competing risk of outcomes related to the heart failure itself may be one of the reasons why it would take a little bit more to see a difference in terms of the effects of flu vaccination. I think that's further supported by the idea that during flu season, where the risks are the highest, that's actually where we did see some benefit from a cardiovascular standpoint with regards to flu vaccination. So I suspect that's probably the biggest difference, the kind of risk related to in the population. But regardless, overall, given the positive findings for hospitalizations and pneumonia, and also the positive cardiovascular findings in the context of flu season, albeit post hoc, I think this is really showing some important benefits regarding vaccination in the context of our current viral pandemic.
Yeah, great point. Great point. There's one final study I'll cover that myself presented today, POISE-3. So we've had a lot of surgical trials, and if you think about it, non-cardiac surgery occurs in almost 300 million people a year. So this is something incredibly common we deal with. Again, we're hearing about a lot of common scenarios where there's not a lot of great data. So one big question that comes up clinically is, blood pressure control. People that are hypertensive, do they hold their medicines or do they take them? Do we allow more permissive hypotension, permissive hypertension? Really a practical question that comes up all the time. So this was part of a 2x2 factorial in the POISE-3, that the tranexamic acid arm. This is a bit different, looking at individuals with hypertension, about 7,000 of them, an international study. And they had a permissive the permissive hypotension arm, where they essentially would only treat you if your blood pressure was under 130. So there are two components, which is if you took your oral medicines, you would hold them on the morning of, and then you would only take them if it was above 130. And then during the surgery, to keep the blood pressure, the mean arterial pressure, above 80. In the other arm, it was a hypertensive treatment strategy where you would take all your meds as usual, and they would only aim to keep your mean arterial pressure above 60. Well, all told, they didn't see any difference in outcomes, pretty comparable outcomes. A lot of nuance here about what was the compliance like and adherence. But when they sort of did all the post-hoc analysis, there really didn't seem to be much of a difference. Now, a bit confusing because we have two components, the taking your blood pressure medicines on the morning of or taking them in a tiered fashion. We also have beta blockers, which we know potentially are cardioprotective. And then we had the mean arterial pressure component in the intra-op phase. So lots of moving parts, but I think all told, what was interesting to me was that it didn't seem to matter. So, when we go back and see our patients in the office, whether or not they take their blood pressure medicines on the day of, or whether or not we hold back and allow a little bit more permissive hypertension, it doesn't seem to matter. And I think that gives us flexibility. Okay, well, I want to thank all our discussants today. What an outstanding group of trials, which certainly are clinically impactful. Thank you all for joining us and giving us your insights on these studies, and look forward to seeing you throughout the sessions.